Good morning. I am Dr. Elias Rolon Mendez from Paraguay. I am doing my neurology rotation with AMIQT, and today I'm going to talk about temporal lobe epilepsy. Okay, I will start with an introduction to this topic. Temporal lobe epilepsy is a focal seizure that originates from a specific region from the temporal lobe, and this condition is characterized by recurrent seizures that arise from the temporal lobe of the brain, and is important because it's present with very diverse and unique characteristics that we need to understand to effectively diagnose and treat our patients, and is the most common of all the adult focal epilepsies. Okay, before talk about the clinical aspect of temporal lobe epilepsy, I want to show you the functional anatomy of the temporal lobe because the classification of the types of temporal lobe epilepsy are based on the functional anatomy of the temporal lobe. Right now, we can see the neocortex of the temporal lobe and all the critical areas that the temporal lobe are controlling, like the language comprehension, the auditory region, and important, the center of behavior, emotion, and motivation. And in this picture, we can see the mesial temporal structures, the hippocampus, the amygdala, and the parahippocampal cortex. Okay, now let's categorize the types of temporal lobe epilepsy, or TLE. Broadly, we classify them based on their functional division within the temporal lobe, a seizure originating from different parts which manifest differently. Now, the, the mesial temporal lobe epilepsies originate from the most medial or mesial part of the temporal lobe, when there is involved older and deeper limb structures like the hippocampus and the amygdala. And then the other types is the neocortical or lateral temporal lobe epilepsy that originates from the outer or lateral surface of the temporal lobe, involving the neocortex. Okay, the most common and clinically significant of these two is the mesial temporal lobe, and it's in this type that we will focus our discussion today. What are the underlying etiologies of the temporal lobe epilepsy? Can be hippocampal sclerosis, tumors, traumatic brain injuries, stroke, and infection. But the most important is the hippocampal sclerosis. Why? And what is the hippocampal sclerosis? It's the most common pathological finding underlying mesial temporal lobe epilepsies. Essentially, it's characterized by the hardening and atrophy of the hippocampus. Now, this is a cross-section of a normal hippocampus with needle staining of the neurons. These darker areas are the neuron bodies, okay? This is a normal hippocampus. Now, we can contrast this image, the anterior image with this. This is a sclerotic hippocampus. And you can notice how the darker areas are lost. And also, the hippocampus is smaller, it's an atrophy. Now, how does this sclerosis develop in an epileptogenic zone? Now, first, we have an epileptogenic lesion. Can be head trauma, stroke, infection, but the most common cause on a hippocampal sclerosis is a febrile seizure in the childhood. Then, because the initial injury, there is a reorganization of the hippocampal. We have neuronal loss and also a reaction of the glial cells called gliosis. And there is formation of scar tissue. And years after that, we have the temporal lobe seizures because this scar formation make the hippocampus seizure prone. Now, let's transition to the clinical presentation. It's crucial to remember that the temporal lobe epilepsy seizures are focal seizures that can be with awareness or without awareness. Now, here is one of the most interesting parts of the temporal lobe epilepsy, the aura. It's crucial to understand that the aura isn't just a feeling before the seizure. It's actually the very beginning of a focal seizure, where the person remains fully awake and aware. This used to be called a simple partial seizure. Now, in the aura, the person can feel a strange smell, a metallic taste, auditory and visual disturbance, and also the feeling of the deja vu. Also, there is a visceral aura called epigastric aura that is a rising discomfort that is coming from the stomach. Now, following the aura comes the main part of the seizure, what we call the ictal, what we call the ictal phase, and this is a focal impaired awareness seizure. During this, the person awareness is changed. They might look away, their eyes open, but they are not truly with you. Their conscious connection to the world is temporarily off. And people and the patient that has the seizure can have automatism, list making, chewing, fidgeting, and also can have involuntary attack or laughter or uncontrollable cry. Now, there is the post-ictal phase, when the patient can suffer from confusion, headaches, and hemiparesis also. Now, how we can evaluate a patient with a suspicion of having a temporal lobe epilepsy? First of all, a history and physical examination, an EEG, and also neuroimaging. Now, in the EEG, we can have some interictal epileptiform discharge, in this case, spikes and chart wave. And also, we can have some ictal EEG recordings. In this case, they are 32-year-old man with right mesial temporal lobe epilepsy, and we can see arrhythmic activity in the right temporal region. Now, we also can use neuroimaging to diagnose the patient. We can use MRI, PET scan, SPET, a functional MRI. So we can be able to visualize the areas in the brain that are affected and that can originate the seizure. Now, once the TLE, the temporal lobe epilepsy, is diagnosed, we have two main ways to manage it and help the patient to be seizure-free: medications and surgery. Okay, antiepileptic medication. The pharmacological management is the first line. We use antiepileptic drugs. We can use lamotrigine, levetiracetam, carbamazepine, etc. What is the goal? The goal is to stop seizure completely with minimal side effect, helping the patient have a good quality of life. But the problem is 1/3 of the patients with TLE, with temporal lobe epilepsy, going to have something called pharmacoresistance. This means that the patient doesn't going to respond well to 2 or more medications. And in this case, the patient going to, for those patients who says you don't respond to medication, we need to consider other options like surgery. For patients with drug-resistant temporal lobe epilepsy, epilepsy surgery can be a life-changing option. The gold standard for mesial temporal lobe epilepsy is anterior temporal lobectomy. This is a operation that is people like highly specialized and experienced neurosurgeons do, And the outcomes in careful chosen people is very good. It's a huge improvement for these people, but also has the risks, like, for example, can have verbal memory deficit or visual problems. The decision for a surgery is always made after a very thorough evaluation by a team of epilepsy specialists. Now, my conclusion. The temporal lobe epilepsy is the most common focal epilepsies in adults. The symptoms are incredibly diverse, and it's crucial to remember that diagnosis and treatment are rapidly improving. Thank you so much.
Hang on.